Good evening, everyone. Can you all hear me well? You can. Thank you. Next slide. I'll be discussing breast cancer genetics, but before we go on to discussion of genetics, let's just first understand that what is the risk of breast cancer. Nearly 1 in 8 women will develop breast cancer, and the new cases that's been estimated to be diagnosed in year 2020 was 330,840 new cases. That's a significant number. Hence, this is very important that we understand how do we diagnose early breast cancer, how do we manage so that we can improve the outcome. As we can see that in 2020, estimated 3.8 million women will be living with breast cancer. Despite of such advances, we still have this as one of the commonest cancer in women in United States and is a leading cause, second leading cause of cancer-related death in United States in women after lung cancer. Next slide, please. The risk factors that we commonly see is the presence of breast is development of risk of developing breast cancer. Hence, we see it commonest thing is in female, although male breast cancer is well described. The risk increases with increasing age. If there is family history of breast cancer, especially first and second degree relatives, then the risk for breast cancer is considered to be higher. Personal history of breast cancer, if there is one-time patient has breast cancer, the contralateral breast cancer risk is higher than average population. There are certain non-cancer related breast diseases can also lead to breast cancer. One of them is atypical ductal hyperplasia. And somewhere down the road during this discussion, Dr. Ferenc probably will cover this regarding biopsies of the breast, when do we do it, and when do we consider that to be followed very closely, and how do we prevent these from pre-malignant condition to become a malignant condition. Prior chest radiation can also increase the risk of developing breast cancer, and that could be sometimes different breast cancer than just invasive breast cancer. It could be even sarcoma of the breast. Hormone replacement therapy mostly is not being done for past almost a decade since awareness of hormone replacement therapy as a risk factor. However, that should be taken into account whenever you diagnose a patient with breast cancer, so that if they are on hormone replacement therapy, that's been discontinued, and patients and family members should be educated regarding hormone replacement therapy and the risk. We unfortunately see that outcome in African American women is somewhat inferior, and it's not quite entirely clear that is it because of delay in diagnosis and lack of awareness, or is it just the biology of the tumor. We also identified that the obesity increases the risk, especially after menopause, and also it increases the risk of reoccurrence. Alcohol is also considered as a risk factor, not an independent risk factor by itself, but certainly increases the risk of developing breast cancer. We have already discussed hormone replacement therapy. However, even contraceptives have considered to be increasing risk factor. Risk factor does go down once they are stopped. Dense breast tissue by itself may not be leading to the breast cancer itself, but the diagnosis sometimes can be obscured, and hence it is considered as one of the risk factors in not so much developing a breast cancer, but inability to detect early on. Not having children before age 30 or not having children at all or not having children before age 30 can increase the risk of breast cancer. Early menarche and late menopause also, because then the extent of exposure to hormone is much higher for the breast, and hence the breast cancer risk increases. Breastfeeding, on the contrary, helps reducing the development of the breast cancer. Physical activity reduces the chance of obesity, and also helps in reducing the risk of development of breast cancer. And so does consumption of alcohol, if it is limited, also helps in reducing the development of the breast cancer. When we look at the incidence of breast cancer, while everybody would like to know, is this genetics, is this hereditary, did I get it because there is some mutation? As such, small number of cases are due to hereditary breast cancer. Majority of them are just a random hit. So 5 to 10% are hereditary causes of gene changes that is inherited from your parent. BRCA1 and BRCA2 are the most common cause of hereditary breast cancer. However, there are many other genes that have been identified that are also included in my next slide, where, next one, please. One would find that there are other genes such as P10, STK11, TP53, CDH1, CHEK2, so on and on and on. There are several genes that have been identified that also can be risk factor for developing breast cancer and passing on to the offsprings. When we look at who are we going to consider to be at risk for developing breast cancer, the lifetime risk of developing breast cancer is about 12% for an average population, and the median age is about 62. However, patients who have BRCA1 mutation, the lifetime risk is about 65%, and the age of developing breast cancer is much earlier in the age, and it's around 43. The median age is 43. For BRCA2 mutation, the lifetime risk is 45%, and the median age of developing breast cancer is 41. Generally, we do genetic testing when patients are diagnosed to have breast cancer younger than age 45, or if there is triple negative breast cancer at any age. Triple negative meaning when the pathologist examines the breast cancer tissue and does the receptor status, if it is estrogen receptor, progesterone receptor, and HER2 receptor negative, that is considered as triple negative breast cancer. And those are generally evaluated for genetics because they could be linked with genetic mutations. Breast cancer that occurs in any one or more first close degree relatives with breast cancer occurring at younger than 50, any family member, first degree or second degree family members with history of ovarian cancer or fallopian tube cancer at any age is important to know, because that patient should be tested and family should be screened if the patient is positive. And male breast cancer at any age is also a risk factor and should be evaluated so that you can not only help the patient, but help the family. Multiple family members with pancreatic cancer and metastatic prostate cancer that is higher grade and occurring at a younger age also is considered that this could be inherited or genetically linked cancer, and the family should be screened for that. 2 or more relatives with breast cancer at any age in any family would also qualify this patient to be tested for genetics. Diffuse gastric cancer and invasive lobular cancer is also linked specifically with CDH1 mutation. And so if the family members have history of gastric cancer and patient is diagnosed to have breast cancer, then that should also automatically be screened or at least referred for genetic counseling and testing. Ashkenazi Jewish population have a higher risk for BRCA1, BRCA2 mutation, and we already covered subsequent 2 or 3 items that are on this slide, which is the male breast cancer at any age, as well as there are other multiple genetic mutations that we have identified that are linked with breast cancer. So as I had mentioned earlier, that only 5 to 10% of cancer that is diagnosed is hereditary. It can be inherited in autosomal dominant or autosomal recessive mode. That's something you may want to understand and discuss when you have genetic counseling done with the geneticist. Each child, whether it is male or a female child, is at equal risk of inheriting that altered gene, and therefore the history on the patient side, whether it is paternal, meaning on father's side of family members or mother's side of family members that are diagnosed to have cancer, is important, not necessarily just on mother's side. As I just mentioned, that altered gene can be inherited from either parent, therefore either parent's family history is important. And once you identify a mutation in a family, then the siblings and children should be tested. Next slide, please. So decisions that helps when you do a genetic diagnosis in a patient is that it helps in identifying how are you going to screen this patient and the family, especially when you are going to decide for the surgery. So surgical options are different when you have this knowledge ahead of the time prior to definitive treatment for the newly diagnosed breast cancer. Also, these patients who have these mutations are at risk for developing other malignancies, and therefore they are at risk for developing other cancers and should be screened and monitored differently, which we can also discuss in our survivorship care plan program. It also helps identifying how are we going to manage this patient and the family members. It offers the predictive testing to the family members and ends the uncertainty or actually gives the certainty. And also it helps to screen them for many other cancers besides breast cancer. Next one, please. So this pie chart may probably will reinforce what I just had mentioned, that sporadic, meaning random chance of developing breast cancer or ovarian cancer is much higher than what you would see in family cluster or what you see as a hereditary breast cancer. Next one, please. So the indication of testing, we already have covered this. So I think that I would move on and not to be repetitive. So one would ask, what is BRCA gene? So we all have this BRCA1 and BRCA2 gene. However, when the gene is mutated and it is not functioning properly, the DNA gets damaged and it does not get repaired. Hence, these cells then can multiply and can become cancerous. So patients who have BRCA1, BRCA2 mutation, these carriers, they have almost nearly 80% chance of developing breast cancer in their lifetime. And as I had mentioned before, that ovarian cancer history is also very important in order to determine the BRCA1, BRCA2 mutations in the family so that you can also diagnose and manage breast cancer earlier. So about 15% of the women with ovarian cancer can carry BRCA1 and BRCA2 mutation. Therefore, if there is a family history of ovarian cancer, even if the mother was 80 years of age and was diagnosed to have ovarian cancer, that patient's family should be screened for BRCA1, BRCA2 mutation. Our preference would be to treat the patient herself if she is alive. If not, then family should be screened for. 47% of the ovarian cancer patients with BRCA mutation have actually no family history. And that is why it is all the more important that when there is an ovarian cancer in the family, that a BRCA mutation gets done. 71% of the ovarian cancer patients with BRCA gene mutation are 50 and older. And BRCA1 mutation patients have 55% chance of developing ovarian cancer. With BRCA2 mutation, there is 25% chance of developing ovarian cancer. So if we were to look at the probability based on just a single feature, as I identified earlier, that male breast cancer at any age is at risk of carrying probable genetic mutation. So the probability is about 8%, which is not a small probability. And therefore, any male breast cancer in the family, one should consider genetic evaluation. Breast cancer younger than 40 have more than 10% chance of having the mutation. Ovarian cancer would be 10 to 15%. If there is a breast and ovarian cancer in particular patient, then there is 86% chance that there is a probability that this mutation is present. And triple negative breast cancer at any age, the probability of this mutation is about 10 to 25%. So the benefits of genetic testing, it certainly ends the uncertainty, do I have a mutation or not? That does not end this uncertainty in reference to monitoring the patient and evaluating. It would be general risk, just like general population screening. General population is always screened, and patients who are negative for this genetic mutation does not mean they should not be screened. They should still be screened, just like for any other patient. And Dr. Ferencz will cover the screening of for the breast cancer a little later. It clarifies the cancer risks of an individual, which we already have gone over those numbers. It clarifies the cancer risk for the relatives. It aids in medical decision-making. How are you going to manage this patient for prevention, for early detection, as well as for treatment? And also, if it's negative, it relieves the anxiety. If it's positive, while it creates anxiety, it also gives you a plan of care. So benefits of genetic testing is significant and should be considered when appropriate. There are always limitations of any test we do. A negative test may be not that uninformative and could be falsely reassuring, and therefore routine screening that is required for anyone should be continued. Patient may prefer not to have their genetic status known for future risk factors for many reasons. Also, there could be some family dynamics that when there are 4 siblings and 3 are positive, 1 is not positive, there is a guilt, there is some resentment, but those dynamics are not as important as identifying and taking actions. So timing of testing may not be optimal in all cases, but based on family history and the incidence of first hit in the family, then at least 10 years before that should be the screening for the rest of the family members. Next slide. And so here is the management of this, that, breast tissue awareness is important. Clinical self-breast exam is very important in patients who have these mutations. So this particular graph identifies that when would you start clinical breast exam in these patients who have moderate and high risk compared to an average risk person? And when would you start screening them? When would you do MRI on these patients? And what other treatments that you can give to reduce the chance of developing cancer? What we call is chemoprevention. And sometimes we offer medication like tamoxifen or raloxifene to reduce the risk. Sometimes we offer intensive screening program with mammography and sonography, as well as MRI on an every 6-month basis alternating. Therefore, patient undergoes MRI once a year and mammogram, sonogram also once a year, June and December. So self-breast exam by physician, proper screening with mammography and sonography, as well as MRI when needed, should be considered. And patients who have such mutations, risk reduction surgeries, including removal of the ovaries and the tubes after childbearing is completed, and also prophylactic risk reduction mastectomies or prophylactic medications like tamoxifen, raloxifene, and even maybe aromatase inhibitors can be offered. I would now rest, and then Dr. Ferenc will start.
So I'm going to talk a little bit about screening to begin. Why is screening important? And screening for breast cancer is important because breast cancers that are found with screening examinations are more likely to be smaller and confined to the breast, early stage breast cancers. The size of breast cancer and the stage of breast cancer, how far it is spread, are all important factors that affect how well people do after treatment and survival. So the screening recommendations from some of the radiology breast imaging groups are to begin mammograms annually at age 40. And these groups agree that this approach is the approach that saves the most lives. Screening should continue as long as a woman is in good health, and life expectancy is 10 years or longer. So mammograms are performed by placing the breast between two plates and taking an X-ray of the breast. This gives us information on the structure of the breast, the architecture of the breast, and whether there's something structurally that's disrupting that architecture. Women who are at average risk should have annual screening mammograms. Women who are calculated to have a higher risk for breast cancer may need to start at an earlier age, depending on the family history or other factors. Women with genetic mutations will need to start screening at earlier ages. And breast MRI, which was previously mentioned, is also a supplement that can be used for some women for high-risk breast cancer screening. So this picture just gives you an idea of what we see when we look at a mammogram. The top four pictures are how we view your mammogram. And this gives you an idea of breast density. So every woman is different. Every woman has a different composition of the breast. And you can see that with the denser types of breast tissue, the appearance of the background tissue is more white. So it has the issue with denser breasts is that it can hide abnormalities, which also come up as appearing white on mammogram. So for women who have the bottom two mammogram pictures that you see here, composition C and composition D, we supplement mammogram screening with ultrasounds, which you can see on the bottom two pictures. The ultrasound can help increase our sensitivity to pick up abnormalities and changes in women who have dense breast tissue. This is a picture of MRI and the MRI setup. This is how a breast MRI is performed in the prone position. And this gives us a good picture of the breast. It looks at the breast like a video instead of a 2D picture like the mammogram. And what the information that we can get from the MRI is different information. It's not better or worse than mammography or ultrasound. Each of these different imaging modalities gives us a different set of information. And you can see the picture that we see on MRI is the picture on the right. And this is a patient who had a breast cancer, and you can see the breast cancer is lit up in the MRI. So after your screening mammogram, you'll get a letter from your ordering provider or your radiologist that describes what they saw and how they interpreted your mammogram. There's different verbiage that's used that sometimes can be scary, but it's important not to jump to conclusions and to talk to your provider, talk to your doctors, to better understand exactly what it is that's going on. An abnormality on your imaging does not always mean that there's a cancer present, but it means that sometimes we need additional information. Sometimes we may need to take a step further and do a biopsy, but it's important that you pay attention to these outcomes and make sure that you follow up for that additional information that we need. Next slide. Some of the symptoms that can arise if breast cancer is developing are a lump, changes in the skin or the nipple. Nipple discharge sometimes can be associated with breast cancers. Changes in the skin such as redness or a rash that's not resolving with typical treatments for infection. All of these can be symptoms of breast cancer, but can also be benign processes. But anytime this is a new symptom that's occurring, you should seek attention with your provider right away so that it can be treated and evaluated properly. So if you have a suspicious finding on exam or imaging or a symptom, what's the next step? The next step is to seek care with your provider, and they will probably start by ordering diagnostic imaging. So you may get additional mammogram images, ultrasound, or MRI, and that's to better evaluate the features of what it is that they're seeing. If there's any suspicious features, you would then move on to biopsy. And biopsy is the way that we can evaluate something that we see structurally on imaging from a pathologic perspective. So that gives us a diagnosis. What is this causing the imaging to look abnormal? The types of biopsies that can be performed include FNA, which is fine needle aspiration, and that's to evaluate fluid or cyst in the breast. Core needle biopsy gives us a little bit more tissue, and that's better for solid appearing tumors. And this can be ultrasound guided by mammogram, which is called stereotactic biopsy. And sometimes we need to do MRI guided biopsies if there's something seen on the MRI that we don't see on mammogram or ultrasound. If we are unable to use the imaging modalities to take a sample of the breast tissue to understand better what's going on, then the next step would be an excisional biopsy. So we can take you to surgery to take a sample and find out what's going on. So what is breast cancer? Breast cancer and cancer in general is an abnormal growth of cells. The cells with cancer can begin to invade and damage normal tissues. And cancer of the breast can arise in any part of the breast. So this picture, the yellow portion on this picture on the top shows the breast tissue. However, that is not where breast tissue is necessarily confined. Breast tissue can be anywhere from the clavicle down to the bottom of the breast, from the midline all the way to the axilla on the side. So breast cancer can arise in any of those regions, and even in the areas where the lymph nodes exist. And those green circles on this picture are the lymph nodes that drain the breast. So this shows on a microscopic level what breast cancer is. And we mentioned before some of the precancerous or high-risk lesions, such as atypical ductal hyperplasia, which the normal duct is seen on the top circle. If you go down progressively, that shows you atypical ductal hyperplasia, which is a risk factor for breast cancer, but it's not a cancer. So women who have atypical overgrowth of the ductal cells will need surgical removal of the area for further evaluation, number one. But number two, they will need to go on to have high-risk screening going forward. That's because atypical ductal hyperplasia is a risk factor for breast cancer developing anywhere in either breast. So we use mammograms and MRIs alternating for high-risk screening in women who have that type of history. If this progresses and there is more atypical cells within the ducts, that's known as a stage 0 breast cancer called ductal carcinoma in situ. Ductal carcinoma in situ is confined within the ducts of the breast. So it's confined to the breast. It doesn't go into the lymph nodes, into other parts of the body. However, we don't know how long it takes, the natural progression for ductal carcinoma in situ to become an invasive or have microinvasion. Microinvasion is when there is a small amount of this cancer that breaks through the walls of the ducts. An invasive ductal cancer on the bottom is when breast cancer has gotten to the point where it may not be contained in the breast. It may spread to the lymph nodes and to other parts of the body. That doesn't mean that that's happened. It just means that we need to make that a part of our evaluation. So the stages of breast cancer, we stage breast cancer 0 through 4, with 0 being ductal carcinoma in situ, which is the earliest stage of breast cancer that we can find. And stage 4 being metastatic breast cancer, which means that breast cancer has spread to other parts of the body. And there are different factors that play a part in how we stage breast cancer. The size of the tumor, whether or not there are lymph nodes involved, whether there is spread to other parts of the body or it's contained within the breast, and also the biology of the tumor. So that's looking at the estrogen receptors, the progesterone receptors, and a protein called HER2. The grade is the degree of abnormality in the cells, and that helps us to, goes into staging as well. But early stage breast cancer, stages 1 and 2, have 99 to 100% survival with the treatments that we have available. So treatment strategies, there are different parts to treatment. Not all women need all parts of treatment. Most women will need surgery, and the types of surgery include lumpectomy, which is removing just the cancer, or mastectomy, which is removing the whole breast, and that can be done with or without reconstruction. And I'll talk a little bit more in depth about that in a moment. Radiation treatment helps with the local control of breast cancer and reducing the risk of cancer coming back to the breast and to the chest. And there's systemic therapies. Some women need chemotherapy, some women need anti-hormonal therapy, and there are some immunotherapies that can also be used in the treatment of some breast cancers. So when we talk about the surgical options for breast cancer, it's important to understand that the type of surgery that you choose does not affect your survival in situations where both types of surgery can be offered. So it depends on a case-by-case basis how large the tumor is, how much of the breast is involved, if there are multiple sites that are involved. So all of that will be evaluated by your physician in order to determine what type of surgery would be best for you. But the types of mastectomy depend on the type of cancer that you have, and as well as the stage of the cancer. A simple mastectomy is when the entire breast, including the skin and the nipple and areola, is removed. Lymph nodes may be removed with this as well. Skin sparing mastectomy is used if a woman wants reconstruction. The skin over the breast is left intact. The nipple and areola are removed in this procedure. However, the breast tissue, nipple and areola are all removed. So the skin that is left is used to help reconstruct the breast in a skin sparing mastectomy. In a nipple sparing mastectomy, and this is appropriate for women who have a cancer that's nowhere near the nipple, certain types of breast may be candidates for nipple sparing mastectomy, where the breast is removed from underneath the skin and the nipple and the areola, and then the reconstruction is performed underneath the skin. There's no nipple sensation after this type of procedure. However, the appearance is a little bit more natural because the natural nipple is there. Modified radical mastectomy is used in situations where we need to remove a large portion of the axillary lymph nodes with surgery. A radical mastectomy is an older surgery. That's what all women with breast cancer used to get. It's almost never done anymore. This includes removal of the breast, the lymph nodes, as well as the chest muscles under the breast. But we've found that radical mastectomy is not necessary and does not change outcomes after cancer treatment. The alternative to removing the whole breast, when the cancer is small enough, you may be a candidate for a lumpectomy. A lumpectomy is where we remove the portion of breast that contains the cancer. And usually, if there's an invasive cancer, you may need to have lymph nodes evaluated as well, which is called a sentinel lymph node biopsy. So we identify which lymph nodes drain the breast first, and those are the lymph nodes that we remove to evaluate. If there is cancer in the lymph nodes, we may need to remove more lymph nodes from under the arm. Or you may need a different order of treatment. Some women who, if we know upfront that there's lymph node involvement, we may offer chemotherapy upfront to try to downstage the tumor and the cancer prior to surgery, potentially avoiding an axillary dissection. And the bottom pictures just show reconstruction. And this is an implant-based reconstruction on the left and a flat-based reconstruction on the right. So who is a good candidate for breast reconstruction? Women who are having a mastectomy and don't have comorbidities that would impair healing, non-smokers, because smoking would impair healing. And if you have realistic goals about restoring the breast doesn't look like the natural breast after it's reconstructed, but women are very satisfied with the appearance of the breast as long as you understand that it won't look the same. Next. So the results vary depending on the type of reconstruction that you have. As I mentioned before, the sensation may be different in the skin, in the nipple, if you have a nipple-sparing mastectomy. So understanding that ahead of time is important to how you feel about your reconstruction after. There are incisions that can be seen with mastectomy. Sometimes there are locations where the incisions can be hidden in certain situations, but not all situations we're able to hide incisions. So sometimes you can see incisions on reconstructed breasts. Implants are used with skin-sparing or nipple-sparing mastectomy, and they can be used either immediately if there's a viable amount of cavity that can take the final implant, or it can be done in a two-part procedure where you need a tissue expander first to ready the cavity for the final implant. And sometimes they use a biological mesh, which is called an acellular dermal matrix, which helps give a little bit more support to the implant and protection of the implant. The implants can be done either under the pectoral muscle, the chest wall muscle, or in front of the chest wall muscle, depending on the anatomy and how well perfused the skin is. So this is a breast reconstruction with implants. The depiction on the left shows you an implant that is under the muscle. And the pictures just show you after stages of healing how a nipple-sparing mastectomy can appear. So reconstruction can be also done with tissue flaps. There are different tissue flaps that can be used. The latissimus is a muscle along the side, and that can be used if the amount of soft tissue is limited. This flap is released from the back and then passed through into the breast cavity where the breast was after mastectomy. And this is where that muscle comes from. So you can see they rotate that flap and reconstruct the breast with the muscle. Abdominal base flaps can also be used. Certain women may be candidates for abdominal base flaps if there's enough tissue. Some limitations are if there are abdominal scars that may limit our ability to use that tissue. With flap-based reconstructions, there are multiple incisions, not only on the chest, but at the donor sites. So with abdominal-based flaps, there will be an incision in the abdomen as well as at the chest, at the donor site and the mastectomy site. So this is where we remove tissue. On the left-hand side, you can see that's the area of tissue that's used for abdominal flaps. And you can see someone with a left-sided on the right-hand side, the right-hand picture, excuse me. She had a left mastectomy, and this is an abdominal flap that was used to reconstruct the breast. Oncoplastic reconstruction is a technique that's used with lumpectomy. At the time of lumpectomy, once the surgical oncologist removes the cancer from the breast, the plastic surgeon can perform a breast reduction, oncoplastic reduction of that side and a lift procedure. So she or he rearranges the tissue of the breast that's remaining. And in some situations in women who have larger breasts, a reduction is performed at the same time. And the opposite breast can also be reduced to create symmetry between the breasts. So in women who are candidates for breast conservation, which is the same as lumpectomy, they can potentially get a breast reduction and lift as part of the reconstructive options. And this picture just depicts someone who had an oncoplastic procedure with lumpectomy. So I will pass it on to, we'll talk about radiation.
Yeah, so I'm the radiation oncologist, and we are part of the oncology team in breast care. As Dr. Ferenc mentioned before, that very often a patient may have a surgery and then will deliver the radiation afterward to keep the area quote unquote clean. Because very often by the time the patient comes to us, the gross disease or whatever lesion that was detected and found has been removed or maybe shrunken down by chemotherapy sometimes. And Dr. Patel will mention that later. So our job is mainly to preserve the organ, preserve the function, and sometimes just to reduce the risk of the disease coming back in the local regional area so that the patient can do better in the long term, in the future, with less worry about the cancer coming back. That's why many patients talk to us and say, hey, I got the surgery, everything seems clean. Why are we giving more radiation? And the reason for that is it's more like a preventative treatment, with data showing us that by adding this treatment, we can greatly reduce the chance of it coming back locally and sometimes even prevent disease from coming back elsewhere. So just like the cartoon of this doctor being like very energetic and fiddling with the tools, we actually have many tools in radiation oncology. And it depends on the situation, who pick the right tool and the right way to treat to optimize not only the cure, but also the cosmesis of the outcome and the effectiveness. And we try to make it efficient too. So we often take into time into consideration. And all these tools may include what we call external beam radiation, or brachytherapy is a short distance, quote unquote, treatment that we might have to do some kind of implant at the surgical site sometimes. And when we deal with the radiation, as I mentioned before, we treat an area. So sometimes we treat a larger area like a whole breast, but sometimes we can even treat partial breast. And actually, one more option with radiation is interesting now is maybe we can do without radiation. We can omit radiation in some patient. So how does radiation really work? First of all, I can't discuss with my patient that cancer cells, they're basically cells with wrong encoding of the DNA that allow them to grow in a uncontrolled fashion. But the radiation is very good in stunning them. So for example, the cancer cell will go from 1 to 2, and then 2 to 4, 4 to 8. But when they see the radiation, they can get stuck at 1 to 2, and then it cannot go on to the next phase. And then hopefully over time, then these cells will then die off. And the type of radiation we use is called ionizing radiation. So it's not just, it's more powerful than what, for example, the X-ray that we use or CAT scan. That's why when we give radiation, we have to be very careful and focus our effort and our aim onto the tissue that we want to protect and treat, and at the same time shield the normal organ and tissue away from the radiation. So yes, even though they get some dose, but they get dose that is safe and is within what we call constraint of the organ and the tissue limits. And how do we generate X-ray? In the past, we have older machine that have the X-ray coming out of actually a piece of radioactive material, which we no longer use because those kind of radiation beams are very fuzzy with a wide edge and it's not precise, and the treatment takes a very long time. So over time, they've developed what they call linear accelerator. So it's electronically generated X-ray, and we can control the power of the X-ray and also shape the oncoming beam of the invisible light. And we can, using those kind of techniques, then we can achieve a highly precise and a protective radiation treatment. So how do we go about from meeting the patient to delivering of the radiation treatment? We start with a consultation. So we got to sit down with the patient, talk to them and find out like, why are you here? How can we use radiation to help or not? Because we want the benefit to definitely outweigh the risk in order to proceed with recommending a type of treatment. And then once we decide if the treatment is appropriate, then we'll decide like for how many days we give the radiation, to what area, and also to what's the strength. And then the next step is, before we start the radiation, and this patient often come in and say, hey, are we starting radiation today? I'll tell them that, oh, unfortunately, no, because we have to do a measurement first. This measurement, we have a jargon, it's called simulation. Simulation means that we are simulating or pretending we're going to treat you with radiation on day 0. But what we're doing is we're measuring the patient in the position as if we're treating them. So it's like a rehearsal. And then after we achieve that kind of measurement, then we go on to the next phase, which is computer planning or calculation. So once we gather the initial setup information, then we can do the computer calculation. That would take maybe like several days. So about a week later, patient can come back to our treatment center after the calculation, and then we set them up again in the exact precision, a precise position as we simulated them in the first place, and start the treatment accordingly. And after the whole treatment is completed, then we just don't stop seeing the patient. We'll then follow up with them in the long term, along with other doctors in the team. And just so you know, the radiation is given most often, Monday through Friday. Patients tend to come in at around the same time slot every day. So they will become I kind of joke with my patients sometimes, say that they are coming back to work for us for a few weeks, and depending on the situation. So sometimes the whole course of radiation could be as short as 16 days, but sometimes it could be up to like 6 weeks or 30 to 33 treatments, depending on the situation of the patient and the kind of condition that we're trying to manage and treat. So here you can see the word simulation again. So who is involved in the simulation? Usually the doctor will be there to direct like which area and give the instruction. And in the United States, we have actually licensed therapists, quote unquote. They're my assistant. They dedicate their time to help with the patient to get on and off the table, because all the treatment is given on the flat surface tabletop to achieve a reproducible physical position. And sometimes this table is not the most comfortable, it's actually a flat slate, but most patients can handle the position well. And during a simulation, in addition to the tabletop, we also sometimes may add certain customized molding that fit to the patient's anatomy individually, and that will help reduce any rotation or movement during radiation. So we kind of look at it as a dress rehearsal for the actual treatment. So in terms of treating breast cancer, we have a couple ways of treating them. One way is what we call supine, meaning that the patient will face up, and we most often use this kind of position when we want to treat the lymph node and also the chest area. And the other kind of setup is called prone, or the patient facing down, and then we have a special tabletop that you can see at the bottom right, that there's an opening for the involved breast area to fall inside this opening. And one of the advantage of the prone position is in our world, when the radiation beam passes through a certain object, we like the object to be more narrow to reduce any potential hotspots. So when the breast is facing down, then it becomes a little bit elongated, a little narrower, and it might reduce the hotspot and then reduce some of the radiation with the side effects such as a sunburn reaction. And sometimes if the breast, which is our target, is falling forward, quote unquote, away from the body, maybe we can even improve the protection of the heart and lung. Next, please. So planning, who is involved in the planning? This is the behind the scene part that you don't see. So after the simulation, you can go home and then relax for a few days while the physician and the dosimetrist, which is my, I'll say my first a person who do the calculation and the mathematics on the computer, and also physicists who are involved in verifying our mathematics and calculation. Because before the radiation is delivered, we have to triple check our calculation, make sure that everything is done correctly. So nowadays, when we do the simulation, we actually use a CAT scanner. In the past, we use a ruler, measure the patient for 2 hours, and that's no good. Now, using a CAT scanner, we can complete the measurement in maybe like 35, 40 minutes. But the information we gather from the CAT scanner is invaluable. In the past, we measured patient with the X-ray with a 2-dimension picture. Now we measure patient in the 3-dimensional way. So by the time the patient leaves the table, in our computer, we have a 3D model or half bust of the body. So with this model, not only we can acquire the previous 2-dimensional information from the past era, we can also see what's inside, which is like the organ, the heart, and the lungs, and we can aim our radiation appropriately while avoiding the normal organ optimally. And we can do it, as you can see on the picture here, left lower hand corner in the prone facing down position where the breast is a little bit dropped down and elongated. And also in the supine position where we can cover the breast, chest wall, and lymph node area accordingly. And one interesting thing about the new kind of radiation is that in the past, when we give radiation, we give a wide margin, trying to cover our target appropriately. But things might move. And now, instead of doing a wide margin, we are able to use a much narrower margin because we use this technique called image registration every day, meaning that we aim first before we deliver the radiation. So our aim is a lot more precise, and that allows us to use a much smaller margin to enclose our target, and that will translate into better treatment, less side effects, and also, more importantly, less radiation or spillover radiation to the normal organ areas, and making the radiation safer. With this kind of treatment, so the image registration or the targeting is done every day. We will see the patient on a weekly basis and examine them because the radiation is given Monday through Friday. I'm literally giving one dose per day. So I like to use an analogy that I'm building a little building, and every day I lay down one floor. And for each patient, I have to get to a certain height for that building to work for them. So around halfway through this building, of the height of the building, that's when the side effects might happen. So the side effects commonly happen around maybe 2 to 3 weeks, depending on the type of schedule that we give our patient. And that's why we want to have a weekly visit with them, so we can check on the skin if there's any other side effects that we can manage. So most commonly we discuss with them like what kind of cream to use, and once in a blue moon we might like add prescription cream or even low dose antibiotics as needed to prevent an infection or treat a greater light infection as needed. But those events are quite rare. And the weekly visit involves again the physician and the nurses. And we'll check the vitals and vital signs and make sure everything is fine. Again, the treatment regimen involves maybe 3 weeks to 6 weeks of a daily radiation treatment. So the faster one, we call that a fancy name, hypofractionation. But the whole idea is, you remember I told you that we're trying to build this building. Hypofraction is almost like I'm building the same building, but I am using a higher ceiling height, so I can stack up faster and reach a treatment that is almost as powerful, but using fewer days. So that's what hypofractionation is. And that has been time proven, especially in Europe and England. So in the United States, we also model after those clinical data, and then we're able to deliver the same kind of treatment nowadays. Daily radiation treatment, again, as I mentioned before, it happened around the same time every day, so patients will have their own schedule. And I sometimes joke with them that, hey, I will bring you back up from a retirement, or you gotta have a little side job with us because you're spending a few weeks with us. Every day they spend about like 15 to 30 minutes with us in the department. The table time actually is shorter. The table time may be like 20 minutes, and within that 20 minutes, we take about maybe like 15 minutes to do the measurement and the image registration, and a few minutes to deliver the actual radiation. So we take a lot more effort and time in aiming than to pressing the button to deliver the treatment. As I mentioned before, we'll meet with the patient on a weekly basis to examine them, and then we'll monitor mainly the side effects and then manage them. With radiation, we always divide the side effects into two kind of profile. The first one is what we call acute, are the ones that we can see and manage during and maybe after the first few months of radiation. And that will include maybe mild sunburn reaction, maybe like some tanning of the skin color. And all these will tend to get better and improve after we start the radiation, and they will most often they will improve back to normal baseline many months after. Next slide, please. So frequently asked question, I always tell my patient up front how many treatment to go, and I will discuss with them using what we call the National Comprehensive Cancer Network guidelines. This is shown nicely like how many treatments are being involved. And then the number of treatment actually depends on the situation and the condition of the patient, and also the type of disease that we're trying to treat. Patients often ask us if we will affect other part of the body. So I will encourage them that we won't. Sometimes the patient may be coming in with some treatment related to some hair loss, but then the hair might be coming back already, and I'll encourage them that during radiation, the hair the hair growth will not be affected, and they tend to be very relieved when they hear that. There's also asked that would they be sick? In the old days, using the much older kind of radiation, we have to constantly check the blood count, make sure that they're not like potentially immunocompromised. But right now, we just get a baseline reading, and we don't even have to check blood count every week anymore. So we don't really affect them that way. We are not aiming at any major organ, so they don't have any nausea, vomiting. They may feel that kind of sensation when we aim at the esophagus, but we no longer do that. So they don't really feel sick. However, they may feel a little bit of fatigue from the radiation, So most of the time, if they have to work full time, they can still work. So I use the analogy that it's almost like they're like a cell phone, the patient themselves. You know how we plug the phone into the for recharge and then you go to 100%, everything working. During the radiation, it's almost like no matter how long I charge the phone, they get stuck at 95%. So everything works, but they feel like a little bit off. And after we're done with the radiation, boom, we go back to 100%. This is another interesting question that I often answer is I assure them they won't be radioactive, they can cross the border, go to the airport, they won't trigger any alarm, they can be safe with their family, with babies, pregnant women, nobody else will be affected because this is not the kind of radiation that they can take home. The radiation that we give is the kind of radiation the tissue can absorb and then that's it. They can exercise. I often encourage my patient to exercise. But only to the degree that is what I call it anaerobic, so they're not huffing and puffing, they're not sweating too much. So a nice walk would be good. And I don't want them to exercise until the muscle is hurting because that's almost in the anabolic phase that the tissue is being broken down and then they might be spending extra energy to repair. So as I was mentioning before, the little bit of fatigue, there's extra energy that the body used to repair on a daily basis because radiation causes some minor side effects, and that extra energy is used leading to that fatigue so that I don't want them to exercise too much to compete with the repair. But otherwise, yes, I do encourage them to do like mild exercise, especially aerobic kind. If any restriction on diet, I kind of a little bit on liberal side, but I do ask them like don't use like vitamins that are in mega dosage, especially those that are antioxidant, because sometimes it might affect the effectiveness in the radiation in an unknown way. But we often encourage them to discuss with us first if they use anything that's specific. Otherwise, that's radiation in a nutshell. We'll see.
So I wanted to go over some information regarding chemotherapy. Not all breast cancer patients need chemotherapy. Particularly patients who have in situ cancer, they do not need chemotherapy. We sometimes give them medications, hormonal therapy, to help reduce the chance of developing second cancer in the other breast or reoccurrence of the cancer that has been diagnosed. Chemotherapy, we give it to patients who have certain unfavorable features, such as very large tumor, multiple lymph nodes that are positive, tumors that are HER2 positive. HER2 positive tumor, actually, particularly, we target with certain antibodies, which is anti-HER2 therapy, such as Herceptin and Brca, which actually improves patients' outcomes significantly. And since it has been discussed in our national meeting in 2005, we have seen that the survival has improved so significantly that when the data was presented in 2005, I don't think there was any oncologist in the audience that wasn't crying. It is that powerful treatment. Triple negative breast cancers, we usually manage with chemotherapy. And patients who have invasive breast cancer that are node negative, sometimes we try to identify that would this patient be benefited from chemotherapy or not. And for that, we specifically do certain molecular genetic testing of their own cancer cells. And based on that, we decide what is the risk of this patient's reoccurrence and would this patient be benefited from further chemotherapy. Because in order to benefit 10% of the cases, we don't want to treat additional 90% of cases unnecessarily. Therefore, Oncotype DX, we often do for ER positive breast cancer, generally node negative, but sometimes even node positive cases, we try to do this test to risk stratify and accordingly use chemotherapy as needed. Sometimes patients who are 70 plus years of age, we try to see what are the other conditions patients have that may actually cause more side effects and short and long-term complications, and maybe not choose to give them chemotherapy. There are different alphabets that you can see on the right-hand side of the slide here, where it says ACT, which is commonly used adriamycin, Cytoxan, followed by Taxol. CMF chemotherapy is also Cytoxan, methotrexate 5-FU. These are alphabet soups with different drugs that we utilize. Generally, when we give chemotherapy to the patient, we are also not only educating them for the names of the drugs and the side effects and the schedule of the drugs, but we also give them printout of each drug for them to take it home so that they can read and understand when to call us, what to expect immediately or in long-term aspect of the treatment. Sometimes we add other medications such as carboplatin, sometimes we give Xeloda. These are chemotherapies that are generally used in adjuvant setting, meaning after a surgery is done. But sometimes some of these medications, we even use it in metastatic settings. And as I outlined earlier, that not everyone needs chemotherapy. Patients who have hormone positive cancer, we can manage these patients, and oftentimes this patient's largest benefit is actually obtained from anti-hormonal therapy rather than chemotherapy. It helps in reducing the risk of developing recurrence of the existing breast cancer and also helps the reduction of the risk of developing second breast cancer in the contralateral breast cancer, meaning the opposite breast cancer. You may have heard some of the medications names such as tamoxifen, anastrozole, letrozole, or exemestane. Some of these medications, such as tamoxifen, we primarily use it in premenopausal patient, whereas in postmenopausal patient, we would like to use aromatase inhibitors because they are actually better in terms of progression-free survival and overall survival of the patient. Generally, the duration of this hormonal therapy is 10 years, but sometimes we give it for 5 years, particularly in situ cancer. Chemotherapy, when we are giving the dosages, the duration, the side effects, it is pretty intense form of discussion, role of Brca, role of echocardiogram. It is a lot. And so patients, we kind of encourage them to ask questions, bring the family members with them. And then each time they come for chemotherapy, they are seen by the physician, by the nurses, so that their questions are addressed. Side effects are also tackled early on. And some of the medications we give to reduce the complications, such as we give growth factors, so that these patients get less chance of developing low blood counts and infection. Sometimes we give them medications ahead of the time to prevent nausea, vomiting, and routinely everyone goes home with a prescription of nausea, vomiting medications. And we encourage our patients to that you should call. If you didn't call, meaning you are well. We do not ever say, why did you call? And also patients who have side effects, we encourage them to come into the office also, whether they have whether they have an appointment or not. So patients who have completed this surgery, chemotherapy, radiation therapy, now, they have many questions that now what now? I'm done with all this treatment. What's going to happen to me? How am I going to be monitored? So there are specific guidelines through NCCN guidelines, which we all try to follow, where there would be how often they are brought into the office for clinical exam, how often we would be doing mammogram, sonogram, as well as sometimes laboratory tests to see if there is any residual effect of previous treatment or if there is new abnormalities that would lead us to say, okay, fine, we need to now do further imaging besides mammogram and sonogram to detect if there was any reoccurrence. It is very important that these patients are followed very closely, and generally they can be followed by breast surgeon, by medical oncologist, and by radiation oncologist. And these appointments can be too many, and often I tell my patients that we could, once their first 2 years are over, that we could alternate with the surgeon so that they don't have to have multiple visits with multiple doctors for the same condition. Next. So the follow-up schedule following chemotherapy, when we are concerned for the side effects, whether it is nausea, vomiting, and dehydration, or whether it is low blood counts, that we generally check them 7 to 10 days after each chemotherapy treatment for the detection of any complications or side effects so that we can prevent hospitalization and delay the treatment. We can prevent that as well. During the first year, most of these patients are followed once every 3 to 6 months, depending upon what stage their cancer was diagnosed in, and subsequently they are followed 6 to 12 months thereafter. And generally after 3 years of follow-up, they are managed and monitored every 6 months to 1 year. And the mammograms are initially done 6 months after completion of the radiation therapy, and subsequently based on what we found in mammogram, what was happening in the contralateral breast when they had a baseline studies, what was found during an initial evaluation for with the MRIs, will help us decide how often we will monitor them, but in general, it is once a year. Next one. Next, please. So survivorship, it is actually very important to know that nearly 90% of the patients who are diagnosed to have breast cancer would be alive and well 5 years or more after the diagnosis. And the survival rate has steadily been improving and increasing in past 20 years due to modernization of treatments from surgery to chemotherapy to radiation therapy to hormonal therapy. And more importantly, early detection. Next, please. So the survivorship actually begins from the time of diagnosis of the cancer. So in the beginning, when they're diagnosed to have cancer, you are living with the diagnosis, you are going through the treatment, and now when you are done with the treatment, how do you live beyond that, and how do you regain your life back, so to speak, and how do you follow up with your physicians, and what do you do to remain cancer-free or to survive with good quality of life. So these patients, as I mentioned, they are monitored very closely for early and late effects of treatments, as well as for surveillance so that we can detect if there was a metastasis to occur or a reoccurrence to occur, then it would be detected early. So as I mentioned, in acute phase, when one is diagnosed, initially you are gathering the information. Okay, what do I do about mammogram, sonogram, genetics, blood test? Who do I see? Which surgeon do I go to? What more test will I need? Do I need an MRI? Do I need a PET scan? Do I need to meet with radiation oncologist? Do I need to meet with breast surgeon and a plastic surgeon? So initial part is gathering all this information. And then comes the active treatment phase, where a surgery is performed, you recover from surgery, and then you undergo radiation therapy or chemotherapy or both, and then ultimately hormonal therapy if it is ER positive disease. And then once again, there is extended follow-up that continues to happen so that patient can get back to, so to speak, normal life. And the survivorship stakeholders are not just the patients only. It's family, children, spouse, and parents, as well as friends and family. So it is not just patient alone. And so the physicians team, surgeons, medical oncologists, and radiation oncologists work together to outline a proper treatment and then ongoing follow-up for the survivorship. The nurse practitioners, the nurse navigators, the oncology nurses, the social work support at the cancer center, the counselors, the spiritual care, radiation therapists, the physician assistant, the pharmacy staff, palliative care physicians who actually also help manage symptoms, not necessarily that this is only for patients who have metastatic disease and are at the end of their lifespan. It is not that. Palliative care physicians can help manage some of these symptoms and can also help coordinate the care. So it is very important that all of us work together to improve these patient's outcome and make the journey as much easier as possible. Genetics, nutrition, physical therapy, career counseling, rehabilitation, all of those factors need to be taken into account in order to improve overall outcome, experience, and maintain the survivorship. In the survivorship care is the prevention of new and recurrent cancer, as well as the late effects of the treatments. So it becomes kind of a lifelong surveillance for these patients. And so depending upon what symptoms and what physical findings that one has identified or the test that one has identified, then how to manage that. Some of these patients have other issues as well, such as psychological stress, financial and social concerns. Those all needs to be addressed, and that is done through the navigation staff, as well as the counselors that we can offer them. The coordination of care between the primary care physician and the specialist is also very important, as some of these patients may not have to be an ongoing follow-up with their oncologist, and ultimately their primary care physicians can pick up the care. And also the acute and late side effects can also be managed through the primary care physicians, whether they have chemotherapy-related effect on their heart, then their specialist would play a role. Whether they have radiation therapy-related underactive thyroid, or whether they have chemotherapy-related low blood counts. Sometimes they develop long-term complications of bone marrow issues. Sometimes they have a chemo brain. So all of that has to be coordinated through their primary care, as well as other specialists who can help improve their overall outcome and get back to, so to speak, normalcy of their life. It is also very important that these patients keep a little diary of the dates of the diagnosis, the treatments, the names and numbers of the physicians, the types of treatment they have received, the test results, what they had, when the tests were performed, so that these ongoing treatment as well as ongoing symptoms and management can be done properly. And even if they are done with all this treatment and they relocated, well, then they would have their own little diary to tell, besides records that are being forwarded to other physicians. So there is a lot more that goes along with this for the survivors, and therefore it is important to be engaged in your own care and have the information with yourself, besides your physicians overlooking the care. The other aspect of this is that how do you change your lifestyle so that your outcome is better? So the healthy eating habits, the diet, the exercise, the smoking cessation, cut back in the alcohol or maybe not consuming it at all. And patients who are on hormonal therapy or they have received chemotherapy, they develop thinning of bones, osteopenia, osteoporosis. All of these testings and appropriate treatment is also essential in order to improve the overall outcome of these patients who have survived the management of cancer.